Hi, this is Dr. Jabbour, and we are going to go over bone tissue today. This is the list of instructional objectives, basically what I'm going to cover. And let's get going. So I'm going to dive right into talking about the cells of bone tissue, which is also called osseous tissue. And these cells are of different functions. We need cells that produce bones and cells that remodel bone by resorbing it. So cells that produce bone are called osteoblast cells. Osteoblasts. And they're the original cells that produce become osteoblasts are called osteogenic cells. These are stem cells that are destined to be bone cells at some point, but they are still immature stem cells, and they reside in the periosteum, the general connective tissue that wraps bones, in the endosteum, which is also general connective tissue that wraps the inner lining of bone. So you have periosteum, endosteum, and then also within osteons, these osteogenic cells line the inner cavity of the central reversion canals. If you remember a little bit of your bone tissue from undergraduate course, the osteons is basically the units of compact bone, and they make up compact bone. We're going to review that in a second. So these osteogenic cells are actually in these different locations ready to go. So if there's stress or need of repair, these osteogenic cells will get activated and will become osteoblasts. And once they become osteoblasts are going to start producing matrix around them. Because remember, bone tissue is a connective tissue. This is a specialized connective tissue. We have cells that are separated by extracellular matrix, and this extracellular matrix is produced by the cells. So these osteoblasts, I tell my students to remember it like that. They have a blast making bone tissue. So the cells are very, very busy producing collagen fibers. I'm going to draw some collagen fibers out here. They're busy producing all of the protein fibers that you would find in extracellular matrix of bone. And also extracellular matrix is made of fibers and ground substance. Hopefully this rings a bell to you. And the ground substance is really just more molecules that have different properties, and some of them have the property of absorbing water, making this extracellular matrix a bit more cushy. So glycosaminoglycan, proteoglycans, glycoproteins, all of these are part of these molecules of the ground substance around the protein fibers. But collagen is the main protein fiber. And there's a specific type of collagen in bone and another type of collagen in cartilage. So anyway, these osteoblasts are very busy releasing all of these proteins that they're making, and it's made, in the rough endoplasmic reticulum, packaged in the Golgi, transported to the membrane, released outside of the cell. And that's how the extracellular matrix gets built up. And once it's built up and calcium ions enter the tissue, it hardens the tissue. So until then, the tissue is a soft bone, and we call it osteoid tissue. Osteoid tissue is soft because it hasn't been mineralized. Once calcium phosphate minerals arrive, and again, this is all via signaling of molecules. Once the signal is sent that we need calcium to come in to harden the bone. Then calcium hardens the extracellular matrix, and the cells, so here's calcium. The cells are trapped in what we call a lacuna, which is this, I give the analogy of a cave. The cell is kind of sitting in a cave like this. And all the way around the cell is just hard tissue. So it's sitting in a cave like this. And another cell is in its own lacuna in a different lamella of the osteon, and they're going to communicate with each other via their cellular extensions through canaliculi. So we're going to have a chance to see that. Okay, so osteocyte is the mature bone cell. It doesn't produce bone matrix anymore. It's just there. It resides in the bone and basically forms is part of the thickness of the bone. Now, to remodel bone, we need a molecule that's going to actually resorb bone, meaning destroying it. And these are called osteoclast cells. So like clash, clash. Like, well, I describe osteoclast as my little Pac-Man. They literally look like Pac-Mans. And they're there to, really destroy bone. And they do it in two ways, with hydrochloric acid and with digestive enzymes. So we'll talk about that a little bit more in a second here. All right, so this was really just an introduction to the two main types of cells, the osteocytes and the osteoclasts. And the osteocyte come from osteoblasts. So these osteogenic cells that give rise to osteoblasts, they, as I said earlier, they reside in the endosteum, periosteum, and the central canals of osteons. Here. They arise from embryonic fibroblasts. We also call these mesenchymal cells, because the mesenchyme is a connective tissue in the embryo. That's the word we use for that type of tissue, but in an embryo, it's called mesenchyme. So mesenchymal cells are your most early connective tissue cells in life. These mesenchymal cells, they're going to turn into osteogenic cells. And of course, because the prefix is osteo, that means these cells are predetermined to become bone tissue. They're on a path molecularly, right? We say it's predetermined to be, future bone cells, as opposed to just being mesenchymal cells. So even, more, less differentiated. Okay, so they turn into osteoblasts, and those are the cells that form the organic matter in the matrix. So mesenchymal cells turn into osteochondroprogenitor cells, and some of them become chondrocytes, and some of them become osteoprogenitors or osteogenic cells, right? This is the same. Osteoprogenitors is the same as osteogenic cells. And what drives these lineages? Molecular messengers. And we understand that now because there's research on all of this with graduate students and working and postdoctoral students or postdoctoral fellows working on all of these molecular pathways and to identify the different molecules that drive a pathway versus another pathway. So now we understand that RUNX2 is a factor that determines the pathway to becoming bone, as opposed to SOX9 is a molecule that is going to drive osteochondroprogenitor cells to become chondrocytes instead of, future osteoblasts and osteocytes. So all of this shows you that it's the molecular messaging, these factors, these proteins that are that come into the tissue and push the tissue to become one kind of another or another. So the osteocytes, when they're finally trapped into their matrix, right? From osteoblasts, they become osteocytes. And we call them osteocytes only when the osteoid tissue hardens and the cells are trapped in the matrix, and they become called osteocytes. So as I mentioned earlier, they're trapped in these caves called lacunae, and how the cells communicate with each other is by gap junctions between their cellular extensions. So I'm going to draw this lacuna around this, and I'm going to draw another lacuna around another cell here. So if I draw the cell inside here in gray, and the lacuna was in black, this is the cellular extension that's going in the canaliculus. So that's the canaliculus. And the canaliculus is the bony tunnel that connects to lacuna, which are the bony caves where the cells are sitting inside. So the cells are inside, and they send this long projection to basically communicate with the cells next door that are also trapped in their own cave. So imagine you are in a room, in a very, very tight room, and there's only a hole in the wall with kind of like a long shaft. And you can only communicate with a person on the other side of the wall by your fingers. You have your arm through that tunnel, and you wiggle your fingers, they wiggle their fingers, and you're able to make, by gap junction, exchanges between each other. So the gap junctions, we learned what gap junctions do. They allow for the movement of ions and nutrients and gases between cells. So that's going to be important because bone is vascularized, but not all throughout. The blood vessels are only running through the central canal of each osteon. So this picture on the left is compact bone, so it's solid. And where does the blood run? It runs through those holes that are the center of each osteon. So each osteon is that unit I was talking about. And at the center of each unit, we have these longitudinal blood vessels running in the length of these osteons. And at certain levels, we also have blood vessels that are running horizontally to connect osteons with each other as well. So these are called Haversian canals, where the central canal, that's also called the Haversian canal, and the canals that are going horizontally between osteons are called Volkmann's canal. So that's something that you must have seen in a previous course. Okay, so these cells, they're kind of trapped in this hard matrix. They have to communicate with each other, and that's how they do it via these canaliculi. And you can see them. Each one of these concentric circles is called a lamella. So from here to here is a lamella, and then here to here is another lamella and another lamella. These concentric lamellae, they're like the rings in a tree. In the trunk of a tree, you cut the tree and you see all of these rings, and basically it tells you the age of the tree because the tree thickens in life. And that's how bone is actually put in place. It thickens by lamella. I'm going to show you how that happens in a little bit. So the layers are added, and every time a layer is added, it basically traps the cells that kind of landed on the previous layer, and they built the layer, and then they get trapped in the layer they just built. So these are the cells right here. They're right here, right here, right here. So these are representing, these black dots are the lacunae with the cells inside. And all of these like wiggly lines, these are the canaliculi. It's just so amazing, so pretty. So these are the canaliculi that are going between lacunae for the cells to communicate with each other. Why? Because we need the nutrients from the central reversion canal. There's the central canal. There's a blood vessel running through here, and we need the nutrients to diffuse from cell to cell to cell to basically provide what every cell needs, even the outermost cells. Okay. The osteoclasts is the second type of cell, right? The osteoblasts that turn into osteocyte, right? We have bone made, but the osteoclasts are the ones that are going to resorb bone. Osteoclasts, they develop in bone marrow by the fusion of up to 50 stem cells together. They're called hematopoietic stem cells. They're the stem cells that are found in the bone marrow. These stem cells are the same stem cells that give rise to a lot of blood cells, the white blood cells, and one of them is monocytes. Monocytes are going to turn into macrophages. Macrophages are big phagocytic cells that are very important in the immune response. And here we have the fusion of so many of these types of cells together. We end up with a multinucleated cell. That becomes an osteoclast. And what makes it an osteoclast is that it has not only all these multiple nuclei, but it has vesicles or lysosomes. Actually, it's right here. These lysosomes right here, it's in green in this particular diagram, in green. These lysosomes are packed with digestive enzymes, and they're going to be released. These digestive enzymes, the lysosomes are going to, by exocytosis, fuse with the membrane, and all of these enzymes are going to end up in the resorption bay, which is the space, which is that space where the osteoclast sits on the bone. And these enzymes are going to start digesting the organic matter of bone. So I'm going to draw my Pac-Man. Here's my Pac-Man cell. And it's very eager to destroy this bone tissue here. And the digestive enzymes, when they're released, they're digesting collagen fibers, for example, which means that they're going to catalyze the cleavage of all of these covalent bonds between the atoms. Also, what is released in the resorption bay is hydrochloric acid. Maybe I'll do it in pink. Hydrochloric acid is also another substance released by osteoclast, and it's going to help release minerals. For example, calcium. And the digestive enzymes help release collagen. So organic matter. Oops, that's the French spelling. Collagen broken down. All right. So these enzymes are enzymes. The enzymes are basically cleaving all of these collagen fibers, and the hydrochloric acid is kind of destroying all of the mineral content, and everything gets released and goes into the blood. And that's how calcium leaves the bone to get into the blood. And we're going to talk about calcium homeostasis later. All right, so this matrix, I kind of verbally already mentioned that it's made of organic matter and inorganic matter. The organic matter is made of those protein fibers, and most of these protein fibers are collagen fibers. But we also have the glycosaminoglycans, the proteoglycans, the glycoproteins. All of these are what we usually kind of describe as part of the ground substance. The ground substance of extracellular matrix. And collagen fibers, reticular fibers, elastic fibers, those are the types of protein fibers that you find in the extracellular matrix outside of this ground substance. So collagen is a very important protein in bone tissue, the same it is in cartilage. Okay, so 25% of bone tissue is organic matter and 25% is water. So that leaves us with 50% of bone tissue actually being inorganic matter. 85% of that inorganic matter is hydroxyapatite, which is crystallized calcium phosphate salts. Calcium phosphate. So calcium phosphate is your most abundant form of calcium in bone. Calcium carbonate is represent 10%, and then remaining 5% of this inorganic matter is fluoride, sulfate, potassium, magnesium. So really calcium is the main component of inorganic matter. I mean, 95% of inorganic matter is calcium. Okay, so let's listen to this. This is really kind of interesting. The combination of organic versus inorganic is really going to have an impact on the properties of the bone, because the combination of both provide strength from the inorganic matter and resilience from the organic matter. So you have that toughness because of the minerals, and you have a little bit of bend because of the collagen fibers and all of these organic molecules. So when there is an imbalance, too much of one, not enough of the other, you end up with a disorder. And I mentioning two as clinical correlation here, always kind of nice to see the consequence of an imbalance. So you realize how important all of these molecules are in the tissue. In osteogenesis imperfecta, which is also called brittle bone disease, you have too much inorganic, or maybe it could be the normal amount of inorganic, but not enough organic matter. There's not enough collagen fibers produced. I'm pretty sure this is a genetic disorder that prevents the production of collagen fibers. So you end up with not enough collagen fibers in the tissue. And the bone, imagine a piece of chalk. And if you kind of like bend on the chalk and touch the chalk and kind of bend on it, it's going to snap. And that's exactly what happens in osteogenesis imperfecta. The bone is too brittle. There's no give. There's no bend. So the opposite is also quite amazing. So the example here I gave is Ricketts disease. It's when bone is too soft. So in this case, it's we could say too much organic matter, not enough inorganic matter, but really the bottom line is we have the organic matter, but we don't have enough minerals to strengthen the bone, so the bone becomes too soft. So actually, let me correct this. Instead of saying too much inorganic, I'm just going to say not enough organic, not enough collagen fibers and all that to give it that bend to it, so it becomes too brittle. And here, not enough minerals. So it's too bendy. And that's literally the case in Ricketts disease, as I mentioned, and the bone is weakened. And when we're talking about the femur that is there to support the pelvis and the rest of the body, you have certain weaker points in the femur, and you end up with a bent bone. So with bowed legs and deformities, the most usual ones are the pelvis, skull, rib cage. Those are common. You can see it on the X-ray. You can see the bend here on the X-ray. You can see it on this, poor child here. This is caused by insufficient calcium intake in the diet, or by vitamin D deficiency, because vitamin D is very important in the absorption of calcium through the intestinal wall. So not only do you need calcium in your diet, but if you don't have enough vitamin D, that calcium is just going to get flushed out and not actually be absorbed. You really need that vitamin D for absorption of the calcium. So these two are the main causes of rickets. So now you understand why. That's why it's so important to understand normal physiology, and that way when you are presented with an abnormal content of this tissue, for example, it makes sense. All right, let's talk now about the skeleton and how is it put in place? How do we end up having a bony fetus? Because the embryo is actually with no bones in the beginning. Early embryonic skeleton is strictly made of connective tissue, fibrous connective tissue, which is the general connective tissue, and hyaline cartilage. No bone yet. So hyaline cartilage is a specialized connective tissue. And fibrous connective tissue, also called mesenchyme, that's a word I had mentioned earlier. Mesenchyme is the general connective tissue in an embryo. And that's it. That's what the embryo is basically a little rubbery structure, life that's just has no bones in it. So osteogenesis, which is the formation of bones, begins at 4 weeks of development. So 4 weeks of development, that's really only 2 weeks after the woman has missed her period, and because conception is at day 14 of the cycle, day 28, 2 weeks later, you're supposed to get your period. You don't have your period, then you're pregnant. And 2 weeks later, that's already 4 weeks of development. So at that point, the embryonic skeleton starts turning from cartilage into bone. And it's fascinating. So there's 2 ways of creating these bones that the embryo is going to turn into, to become the fetus with the skeleton in it, by intramembranous ossification. And it's a different way of making bone. It's a fibrous membrane model. So I'm going to explain that. And there's also another way of making bone. It's called endochondral ossification. And this one uses the hyaline cartilage model. So both of these connective tissues are at the source of bone formation. One is used for flat bone formations, and the other one is used for long bone formation. So any flat bone, like the sternum, the flat bones of the skull, all of these flat bones are produced by intramembranous ossification, and long bones like femur, humerus are produced by endochondral ossification. So let's see intramembranous ossification. So this is the summary of how it works. It's going to start with mesenchyme that's going to condense, and osteoblasts are going to arrive, blah, blah, blah. So I wrote it here as a summary. I probably should have moved that slide after my drawing. I prefer to draw it out so you can see, instead of just a list of words, of what's going on. Because if you see it, and I want you to draw it too yourself, if you draw it, it's the active process of learning what's happening. So I'm going to draw first the mesenchymal cells, mesenchymal stem cells, mesenchymal stem cells, in black here. And the first thing they do is they start condensing. Condensing means they kind of come together, they huddle together, and they're just closer to each other, right here. And they're all communicating with each other, saying, hey, there's a party here, let's kind of like meet up, let's meet up, yes, let's meet up. And they're all kind of like joining this group of cells. So the mesenchyme condenses. And the second step, osteoblasts form osteoid tissue. So this mesenchyme is basically the scaffold for the osteoblast to come in and land here and start forming bone tissue. Well, really, these cells are basically transforming into osteoblasts because these are the original cells. So they kind of form this scaffold of what it should be, and then slowly they turn into osteoblasts, and then the osteoblasts start producing the actual matrix. So these mesenchymal stem cells are not producing any matrix, they're not producing any bone tissue, but they line up where bone should be put in place. So they line up flat like that, all huddled together. They start turning into osteoblasts, and the osteoblasts start producing the matrix. Okay, so you end up with this soft osteoid tissue. This is soft osteoid tissue. Okay, so when the soft osteoid tissue is put down, then you have calcium that's going to be signaled to come over and start crystallizing on all of these collagen fibers. And now the soft osteoid tissue becomes hard bone because of the arrival of calcium. Okay, so you end up with hard bone, and I'm going to show you. So I'm going to draw a hard bone in dark blue, right? So this is your hard bone. Right? All of these osteoblasts, they turn into osteoclasts, and this is like just all hard bone. What you're left with is a little bit of osteoblasts that are just kind of left on the outer surface. And this is basically your future periosteum. Your future periosteum, so it's connective tissue. So a hard compact bone, like it's, I don't know, it's not compact. There's no organization of osteons here, but this just, it's full. This is a full hard bone in this thickness. Our flat bones are not made of a full hard bone structure. It's actually not like that. I think I have a picture a little bit later to show you the final outcome, but I'm going to actually draw it out now. So what arrives next are your osteoclasts. So here's my Pac-Man. And these osteoclasts, they're going to remodel bone. and it's going to destroy the center of these flat, thick, bony structures. And you're going to end up with a spongy bone with all of these trabeculae. So I'm going to draw the outcome over here. You're going to be left with a little bit of hard bone over here. Because spongy bone is never exposed, and then you end up with just the trabeculae in the center as a result of the remodeling from the osteoclast. So this is spongy bone in the center. So from the result of the osteoclast activity, I'm going to draw this arrow over here. You end up with this compact bone, spongy bone, compact bone layering. You still have your less mature osteoblasts on the edges, and that's the periosteum. There we go. That's the periosteum. Okay, so that's how we have flat bones set up. They're actually a layer of compact bone, spongy bone in the middle, and compact bone on the other side. And it's a sandwich layer. So think of your skull. Is there a picture? Did I? Let's see. No, I'm surprised. I'm thinking of a picture in my undergraduate lecture. It's a picture of an actual flat bone sawed, and then you can see inside, and it's all spongy. So really, a flat bone, when you look at it on the outside, it's just solid, right? The surface of a skull is just solid. That's the compact bone, and it can be very thin. And then all inside is actually trabeculae, and on the inner side, right? If you turn the skull upside down and you look underneath the calvera, it's a solid surface. There's compact bone. So it's two thin layers of compact bone and spongy bone in between. Why? To lighten up the bone and also to create this absorption for the shock. So if you have shock on the surface of your, like you get hit on the head, you might crack an outer layer of compact bone, and the shock is actually going to get dispersed into the space here, and you might not crack the inner layer of compact bone. And basically that's how you protect the brain below. If I'm talking about, a frontal bone or a parietal bone and you get hit on the head like that. So the crack might just be on the outer compact bone layer and not, hit the brain. And that's how it's set up. So it's really, really cool how it's planned like this. So let's look back at this summary. Osteoblasts form osteotissue. Calcium phosphate is deposited. So now the tissue is hardened. Osteoclasts have to come to remodel the center because we don't want these flat bones to be as heavy. And we end up with a remodeled center, which is much lighter, and a surface mesenchyme that will end up being the future periosteum. So this makes the flat bones lighter with this spongy bone in the center, but also absorbs the shock from an outer hit. All right, so now let's talk about endochondral ossification. So just like for the other one, I wrote a summary here. It's the ossification method that's used for really all bones below base of the skull, and especially long bones. So I'm going to use the example of a long bone and how it's produced. I'm going to draw it out, and it begins as a primary ossification center in the cartilaginous model during the second month of development. So let's talk about that. So I have several slides that are going to be drawings, and if you can draw with me, it would be great. Or plan to redraw it on your own. It all starts which is so incredible, with a cartilage model. So I'm going to draw this long, oopsie, I'm starting already. Trying to get the best position here. All right, so there we go. It's a bit wonky. Cartilage model. This is like a rubber bone, the ones you buy for your dog. It's just all rubber, and it's but it has the shape. It has the shape of the future long bone, and that's what's so cool is that your entire skeleton was at one point all cartilage. So the ends of long bones are called epiphysis. You know, I'm going to okay, I don't know. There's a little delay between my pen and the writing, and it's kind of annoying. So the epiphysis are the heads of these long bones, and the diaphysis to write a little bit slower. The diaphysis is the shaft, and it's all regular hyaline cartilage. This is made with hyaline cartilage. This is definitely forcing me to slow down so it writes properly. So what does hyaline cartilage looks like? The cells are kind of a bit stellate. I'm just going to draw them round. So you have a cell here, and you have another cell here, and you have another cell here. Okay, so they're all residing kind of next to each other. They're not touching each other. And you have, of course, the extracellular matrix between them, right? And this is an extracellular matrix that is rich in hyaluronic acid, and the glycosaminoglycans in cartilage are a little bit different than the ones in bone. They absorb water in a different way. It gives the cartilage this bouncy property to it, this rubbery property to it. It's not a fluid, but it's not hard either. So it's a very special connective tissue. So we talk about the lacuna. It's the same word that we use for bone. It's the same for cartilage cells, which, by the way, are called chondrocytes. So these chondrocytes are trapped in the matrix they made. They used to be chondroblasts. That's very similar to what's going on in bone. Chondroblasts turn into chondrocytes, and same thing. The chondroblasts are the ones having a blast, making all of the matrix around them. And once this matrix becomes this rubbery matrix because of the content of the extracellular matrix attracting water and making it rubbery, then the cells are like trapped in this rubber space. So the space they're in is called the lacuna, and everything around is that extracellular matrix that's kind of rubbery. So every cell is kind of trapped in their own lacunae, and cartilage is non-vascular. And so these cells are relying on the diffusion of nutrients and gases from nearby tissues. That's really important, and that's why hyaline cartilage has a hard time to heal more than bone tissue. Okay. So that's what I wanted to do to actually show you how the story starts. At 2 months in utero, so let's now do a second attempt at a better bone here. Here we go. So at 2 months, so now we're not talking about 4 weeks, we're talking about 8 weeks, 8 weeks of development, right? 8 weeks in utero. We're still talking about in utero. This is an embryo that is just kind of just cartilaginous. So at 2 months in utero, what we have is a primary center of ossification that starts building up. We have a primary center of ossification. And it happens right here in the center of the diaphysis. So how does it start? It starts because we have perichondrium around the cartilage. So there is this connective tissue called perichondrium. And perichondrium contains very immature cells that are going to turn into osteoblasts, which will help build bone. So perichondrium is doing this at the primary center of ossification, which is right here. So I'm gonna put a 1 here. And of course, what we have here are all of the lacunae as we saw in the previous slide. I'm going to draw them a little bit smaller here. The cells, this is a normal cartilage cells with extracellular matrix. This is all normal in the center of that diaphysis. All right. So these cells are going to start thinning out. They are messengers via blood. So whatever the vascularization around this is, they are messengers that are going to leave blood, diffuse into the center here, and tell these cells, you are not longer, permitted to stay in this state. You have to start swelling. And these cells are like, what? Why? And they start just getting bigger. And they're not sure what's happening. They're kind of like, why are we getting bigger like that? It's not a good sign. So these factors that are coming in, diffusing into the cartilage and basically pushing for hypertrophy. This is what's happening here. It's called hypertrophy. These cells are enlarging, and it's basically the beginning of the end for them. That's why they're kind of like worried. So what's going on here? Let me erase a couple of cells. I need space here, actually. I'll draw another one here. So what's happening here, so we're zooming in on these cells and we see that they're much bigger now. And what's happening is that the extracellular matrix is much thinner, much thinner. Because the lacunae are enlarging, the cells are enlarging, the lacunae are enlarging, imagine them like being bloated, right? They're enlarging, they're swelling, and the lacunae kind of enlarge, and that basically brings them closer to each other because they were kind of far apart with matrix between them. Right here, they were happy. And when they enlarge, the matrix becomes thinner. And when the matrix is thinner in the center of the diaphysis, that is a problem for the structure of this this bone, this future bone. So it's still cartilaginous. So you have this I'm just going to call it structure. The structure at the center of the diaphysis, you have very thin matrix and very enlarged cells. So it actually compromises the stability of it, and it's going to kind of fall over if we don't do something about it, which is what happens next. So because of this perichondrium, the presence of this perichondrium, we're going to have a bony collar produced there as a splint to prevent the center of that bony structure, but it's still not bone yet, from falling. So to prevent it from falling, right? So this is the same bone, but now we have a collar that's being built just on the outside to basically act as a splint. So there's a splint here. And that's the bony collar. Okay. Okay, so inside this space, by then, now you're completely blocking off the nutrients from arriving, because now you put bone here. So the blood vessels that were kind of running nearby, and helping diffuse here. Now that you have a hard bony collar, you're not able to diffuse nutrients to the cells, and the cells are going to definitely die by then. So all of these swollen cells are dead. Okay, so I just want to clarify this on the left here, I drew in dotted blue here the perichondrium. This was a connective tissue. Chemicals and nutrients and gases could still diffuse from the blood into this hyaline cartilage model. That was still feasible. But once we had this hypertrophy going on in the center, that's why we call it the primary center of ossification. This is where ossification starts first, right there in the center of the diaphysis. When we had the center compromised and we had to create a splint, we took cells, progenitor cells from the perichondrium, and turned them into osteoblasts that created this bony collar. And whoop, now you have this cartilage model that stayed erect because of this bony collar. Okay. So the bony collar basically helps accelerate the death of the cells. So what happens next, I'm going to show you just the center, and I'm not going to draw the whole bone anymore. In what we have, so this is what happens next. We have these very large lacunae that are empty. These are empty lacunae. They're empty because the cells died. The lacunae remain because the lacuna, each lacuna is just the walls where the cell sits. It's the cave. The walls of the cave don't disappear. It's just the cell that was sitting inside that cave, trapped in that cave, that died. So the lacunae are still there, but they're empty, and the matrix is still thin. That was the whole problem to begin with. So very thin, thin, thin matrix. It is so thin that actually it can break. So what happens is that we're going to see the blood vessel from the outside is going to be able to break through this periosteum, boom, just like that. And this blood vessel is going to be able to get in. So we call this a periosteal bud. Periosteal because it comes from around the periosteum, and it's going to, you know, periosteal because it comes from around the bone. Peri, around, osteum is referring to the bone. It's the bony collar. So it's breaking through the bony collar. And what it's going to be bringing are progenitor cells that will turn into osteoblasts. And how are we able to get in here? Because the walls are brittle. I'm going to write it in that thin, brittle walls. Oopsie. Brittle walls. Okay, so because the walls are brittle, when this blood vessel kind of gets through a hole in the bony collar and gets into that the matrix, this very brittle matrix. And by the way, I forgot to mention, it's brittle because there's also calcium ions that deposited and kind of made it hard and brittle. So the calcium ions deposited and made it brittle. So it was already thin, and then you have calcium ions coming in. Now it's brittle, thin and brittle. So when the blood vessel kind of pokes through, it literally can break a passage to get to these caves. And it opens the caves to each other. So I'm going to show you what ends up being is these kind of long tunnels that are pierced by these blood vessels. So all of these are the original lacunae, but now they're broken. The blood vessel was able to kind of like dive through and bring very, very special cells with it. Okay, so it's bringing these cells, and these cells are basically being deposited by this blood vessel. So what they do is they kind of land on this wall over here. Remember, this is an empty cave. And basically, these cells are told, okay, here you are the, osteoblasts. These are progenitor cells that are coming via circulation, from the outside in, and they're basically being plastered all over these empty walls. And they're told, paint, go ahead, do your thing, and create bone tissue all over the walls. And that's what they're going to do. They're going to start putting down bone tissue. That's the first thing they do. And that's your first layer of bone tissue. So you have this layer of bone tissue here, layer of bone tissue here. They're very busy. And they produce bone tissue. So this is the first layer of bone tissue. And then when this first layer of bone tissue that's still soft hardens, because we have arrival of calcium ions. So this turns into hard bone, and I think hard bone was illustrated by the dark blue. You end up with your first lamella. This is your first concentric lamella. And then another layer is going to be deposited. And we're going to make another lamella. So every layer creates another lamella. See, this is one lamella. And then another lamella and another lamella. So the lamellas are basically the put in place because we are spray painting this lacuna. We're blasting all of these osteoblasts. We're putting all these osteoblasts on the walls, and we're telling them create bone tissue. So they produce the osteoid soft bone tissue, which then gets calcified, becomes hard. Once that's hard, that first lamella is hard, well, let's spray paint on that. So the new wall is basically the surface of this first lamella. And now we spray paint that new wall and create another layer, another lamella, and so on and so forth. And every time it's with a fresh batch of osteoblasts that lay on this, new layer, the next layer, and the next layer. So that's how the osteoblast gets trapped between the layers, and you end up with, all of these lacunae that are visible trapped right at the edge between two lamella. Isn't this beautiful? This is exactly how osteons are being built. So here we are. I'm going to redraw the cartilaginous bone model. But this time it has bone at the center. So I'm going to draw blood vessel. And by the way, bones are penetrated by blood vessels. And I'm going to draw the osteons. So osteons are basically all of these concentric lamellae that were put in place during endochondral ossification. And the blood vessel is doing its job by running through all of these and they can even connect with each other via Volkmann's canal. So the central eversion canal in each osteon is just that. It allows for the vessels to run vertically throughout this compact bone. So if we wanted to kind of like just see it a little bit more, that's what we have. We have one osteon next to another osteon. And another osteon, next to it, behind it. Anyway, I think you see the picture now. And these are the blood vessels that are running through every one of these osteons. Okay. So this is great, but this is not really how diaphysis of long bones actually end up being, because we need a marrow cavity. So this is not going to be good enough. We need to have osteoclasts that come in to resorb this middle. This is too much compact bone. If all of our long bones were just full of compact bone, we would be walking like, we would be so heavy. And that's why the center gets remodeled with the arrival of osteoclasts. So I'm going to draw osteoclasts. I think I was drawing them in orange. So osteoclasts, they arrive again with the blood vessels, they arrive through the blood, and they basically get diffused into the tissue to start resorbing the bone. So in the end, without going to the details of the resorption process, I kind of already explained that this is what we end up getting. So by the time the baby needs to come out by birth, we have long bones have really just their epiphysis cartilaginous. Let's draw that without hesitating. And their diaphysis completely bony. And there's the other epiphysis. Okay. So completely bony, that means that we have remnants of compact bone. This would be, all of your compact bone, the osteons, right? So if we had to draw the osteons, it would be in this direction, right? All these osteons going this way. This is all compact bone. I could have used like the dark blue, that's okay. And we have what's called over here growth plates. So right here, no, not yet, sorry, I'm so sorry. So we have the epiphysis still as hyaline cartilage. This is still hyaline cartilage. Jump the gun. And this is a bony diaphysis. This is bone with a marrow cavity and marrow going through. This is marrow. All right. So this is before birth. At birth, we're here, we have all of these sticks, and the heads of those long bones are still cartilaginous. So we need to continue turning these heads into bony parts, and that happens after birth. So I'm going to draw the secondary center of ossification, which is after birth. So at birth, so secondary center of ossification, secondary center of ossification starts at birth. When technology is a bit lagging here, the connection maybe. It's frustrating. I like it when it writes smoothly, but it's not. Okay, so what does that mean? That means we have what we saw in the shaft or during development is going to happen now in the epiphysis. Okay, so secondary center of ossification takes place in the center of each diaphysis. That's it. And what we're going to have, you're going to have the same story. You're going to have lacunae that are going to enlarge, and the extracellular matrix is going to thin out. There's no bony collar in this particular situation because we're not in the middle of a long shaft. So there's no, structural integrity at risk here. So we're just going to have the shift into bone tissue directly without even the bony collar. So you're going to have the periosteal bud and bone formation and bone remodeling. So you're going to end up with spongy bone in the center over here, just like we had spongy bone in the center of the diaphysis. So the center is completely open for the marrow cavity, but the surface here is actually made of these trabeculae that are typical of spongy bone. Trabeculae and spaces and trabeculae. So if you run your finger in the inside of the shaft of a long bone, it's actually not smooth. It's very rough because of all these spongy bone, trabeculae of spongy bone. So I'm just going to draw the final bone. I'm going to draw it. Okay, so this is my long bone. So what's left at the end of secondary center of ossification? When all is said and done, what you have left, you have some hyaline cartilage left on the surface of the epiphysis. So I'm using those colors on purpose because this is leftover hyaline cartilage. And basically, this is your future articular cartilage. This is what's going to be the cartilage that's going to articulate with the cartilage on the opposite bone at a joint. And you have leftover hyaline cartilage over here at the edge of the epiphysis and diaphysis. And this is your growth plate. So when the baby is born, this growth plate is going to, after birth, it's going to allow for the growth of the bones in length because, the baby has to be born at a certain size and then grow into the adult size, after birth. So once we have the bony structures put in place in the epiphysis, which is, your layer of compact bone on the outside and complete spongy bone on the inside. So this is very important that you understand that. Compact bone, spongy bone. This is spongy. This is compact. So same here. So this is compact on the outside and a very, very thin layer of spongy on the surface and then complete open cavity in the middle. So the growth plate is basically what's left between the epiphysis and diaphysis, and it's also called the epiphyseal plate. Epiphyseal. Let me see if I can adjust another setting here. Oh no. Oh, let me do something here. Maybe that's going to help. There we go. Hopefully this will help with the writing. I tweaked something on my trackpad. Maybe. We'll see. Okay. So now we have to talk about this growth plate. All right, so before we get into the nitty-gritty of the growth plates, here is a few pictures of this whole process, right? So I just described it. And by the way, the summary was in the beginning. Primary center of ossification during the second month of development. At 3 months of age, the primary marrow space is formed. I didn't add that chronology in my drawings. by the periosteal bud. I did mention that verbally. Secondary center of ossification begins after birth or near time of birth, at birth. Same process as primary center of ossification. And you have some hyaline cartilage that remains either on the surface of the epiphysis, and that will be articular cartilage at joints, or at the junction of the diaphysis and epiphysis, forming the epiphyseal plate. So if you, this is one of the diagrams you find in textbooks with bony collar, primary center of ossification, and this is, you know, jumping here from here to here. Now we're even seeing secondary center of ossification in the epiphysis and the growth plate between the edges. All right, and this is so awesome. These are the little phalanges. I'm pretty sure this is from a rabbit embryo. And you see their little phalanges in their toes. I think this is a toe. And these are, these little phalanges used to be all cartilaginous, which is exactly what this is. This is your typical, beautiful, right here, hyaline cartilage. And at the center of these long bones, so this is one long bone, this is another long bone, and this is a long bone down here. So these phalanges, they're each mini long bones. And then at the center, let's see if I can zoom in here. You can see the lacunae being enlarged. You see that? These lacunae are so big. Here they're normally much smaller, and it's very purple because the matrix is, you know, very thick. But here the lacunae are so wide, the matrix just becomes this thin purple line in between the lacunae. So the center looks like this whitish look to it. That's because that's the primary center of ossification right there. So it's so cool to see. And you can see skin, and this is, I believe, hair bulbs. There's skin and stratum corneum here. Very cool. All right. Yeah, hair follicle, I was right. And developing bone, epiphysis, diaphysis. Yeah. So these are just so cool to look at. So again, another view. Yes, that's right. I forgot I had this bigger view of it. And we're going to actually, even in the next slide, no, it's not in the next slide. But that's a close-up enough. You see, so you have your beautiful hyaline cartilage over here. This is normal hyaline cartilage. And then this is the center of ossification. And you can see these lacunae are much bigger, and and the matrix is much thinner. You can see that. You can see these lines. They're very thin lines. And some of these lacunae look like they still have a cell in them. You see, these are cells, but a lot of them are empty. This is empty, empty, empty. The cells are dying. They're not going to be there. And look what's so cool about this. And you can see here the periosteal bud. This is where there's a breach in the periosteum. So this looks to be the staining for the periosteum is over here. This is periosteum, that bony collar. And here's a breach. And you can see these blood cells. You can see them in pink here. This is coming from the outside. Right? And they're going to start to deposit inside these lacunae and create bone. So hyaline cartilage, and so this is that labeled. Okay, so another picture. Here we go. So this is a picture of a 12-week-old or 12 weeks fetal skeleton. So at 12 weeks, we call it a fetus, and you can see the bones are just little sticks. The humerus, a radius, and ulna parallel to each other here, and you don't see nothing in between. You don't see epiphysis, you don't see the heads, you just see the shafts, because that's all we have at 12 weeks. We just still have bones being put in place because we're up to 12 weeks now, but not the epiphysis yet, because we're far from birth. It starts right before birth. Secondary sign of ossification, right before birth. These are just beautiful pictures of developing bones. And I want to point out to you this remnants of hyaline cartilage in this particular preparation. The cartilage was stained in purple, and the bone the cartilage was stained in blue, and the bone was stained in purple. So here we're zooming in on this growth plate, the epiphyseal plate, because we need to talk about the metaphysis. And the metaphysis is this region of change. It's this region where we can create bone out of what's in that region, which is a collection of cartilage cells that are transitioning from being cartilage cells to being bone cells. So I want to show you here the metaphysis. Let's see. We're going to cover 5 zones in the metaphysis. So this would be zone 1, zone 2, 3. This looks like around zone 4 and zone 5. So it's literally like this. It's going to evolve from being just plain hyaline cartilage. Regular hyaline cartilage is over here. This is it. This zone 1 is kind of thin. In other preparations, we see a thicker zone 1. There's regular hyaline cartilage, kind of just your normal hyaline cartilage. And then all of these cells that are in their lacunae, far apart, just hanging out, they start lining up. So I'm going to talk about this lining up of cells and what happens here, and the swelling of the lacunae, and then the marrow invading. It's a really, really, really cool story. So let's talk about these different zones in that metaphysis. So I'm describing what's in the metaphysis and what's going on in these different zones. And I'd like you to know that. So the first zone that I labeled 1 in the previous picture is zone of reserve. Zone of reserve. And zone of reserve is your just regular hyaline cartilage look to it, with lacunae that are far apart. Some of them, lacunae sometimes are found in pairs. And they're kind of just with extracellular matrix around them, just a regular looking hyaline cartilage, This is called zone of reserve. This is like your source of cells to make bones. Okay, so what happens to these cells? They're going to start proliferating. So this next zone is called zone of proliferation. I'm just going to stop here. Proliferation. So that means that they are going to start increasing in numbers. So instead of being kind of like one here, one there, one here, one there, they start increasing in numbers, and they start lining up in columns. Zone of proliferation. So I'm going to write here, just so you're aware, increase in numbers and columns. Okay, two things are happening. They are multiplying, which is not a thing that happens in hyaline cartilage ever. Cells don't just like multiply. But here, because of, again, factors that are kind of coming in, and well, it's growth factor that's coming in. These are, hormones and other messenger molecules that are coming in to drive this proliferation. So the proliferation is going to be happening where the cells multiply in numbers, and all of a sudden we just kind of boom, 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 line up in rows. So zone 3, this is where cells are starting to get, a signal of, this is really, we're not on the right path here for our, our survival. Because here it's zone of hypertrophy. Hypertrophy. What that means, hypertrophy, it's a word you really need to know. It's the swelling of the lacunae. So these lined up cells in their lacunae are now swelling up, and they know something is not good. Something is not good. Let me swell these up a little bit more. Okay. So they're like, "Wait, what's going on here? I don't know. Have you heard something? I have no idea, but I'm like not liking this. Me neither. Oh my gosh." So zone of hypertrophy, they're just swelling. They're not doing good. They're like, what's going on here? I don't know, but we're just feeling very bloated. And it's like, oh my gosh. They're just not doing well. So the cells inside these lacunae are not doing well. And then we arrive in the 4th zone, that's zone of calcification. So what happens in zone of calcification is we have these cells that are just dying, right? Inside the lacunae, the cells are dying. But what's happening is that we have calcium phosphate deposits. There's a lag. Calcium phosphate deposits, by then the cells are just, they're gonna die. And the lacunae are empty, right? So the cells die, the lacunae are empty. Okay. Zone of calcification. That is not bone formation, but it's calcification. We have calcium ions that come and deposit in this thinned out matrix because we have these swelling of the lacunae, so the matrix is thinner. That's kind of like the same thing happening as we saw in the primary sign of ossification. And you have deposit of calcium, so this is going to be very brittle. Thin cartilage matrix that's very brittle. Okay, so finally, let's get to the zone where we're going to finally make bone. And this is in zone 5, zone of ossification. Now we're making bone, ossification, or we also call it bone deposition. Bone deposition. So let me show you how that works. So we have these lacunae that are so brittle, they basically crack open. And remember, at this end, we have marrow. I'm going to draw it in pink. Marrow. And marrow is going to rush in as soon as it can, right? It's going to break these very brittle walls and kind of like pierce through from below and shoot up like a hose and start uh, um, uh, painting these lacunae tunnels. Like now we literally have like these long tunnels of lacunae that are open to each other. See how these lacunae, and that's why they're lined up. They're lined up to form these big columns. And as soon as we can break through the bottom, we can actually fill. These are empty columns because the cells died. They're not there anymore. So we have ghost towns. We have these empty lacunae that we need to fill up with actual bone tissue. So the marrow brings in osteogenic cells. I'm just going to write osteo here. Osteogenic cells that will turn into osteoblasts and will basically produce your first lamella. And then you'll have a second lamella produced, and then you'll have a third lamella. And every time we add a lamella, and it hardens, then we add the second lamella and it hardens, and another one, until we reach the center, and then we leave it open for the blood vessels to go through. Okay, okay. So how is this bone formation? Because here we're making bone right here. Bone. So you have to also have some osteoclast activity. So I'm going to add them here as well. Osteoclasts, they come from the bone marrow as well. So osteo here was referring to osteogenic cells that turn into osteoblasts and they produce bone. But in the center, we need a little bit of osteoclast activity to kind of keep going with that marrow cavity. We don't want it to be completely solid. We need to open that marrow cavity. And look at this. Look how we ended up growing the bone. Zone of proliferation means more cells, and we're lining up into column. That is pushing the zone above upwards. And when the cells swell, they take more space, so that pushes all the layers above upwards. So really, zone 2 and 3 are responsible for the length, for the growth and length of the bone. And that's what happens at the metaphysis. So I want to come back to that last drawing I did here. So I'm talking about this region here from, I'm just going to do black here, from 1 to 5 in this direction. The same thing happens in the opposite end from 1 to 5. And 5, the zone 5 is the zone facing the marrow cavity. So the marrow over here is what's going to like break into these very brittle calcified lacunae walls and bring in the osteogenic cells that are kind of sitting in the bone marrow. And these osteogenic cells will produce bone, and we're going to have a little bit more bone made here. So maybe I'll draw it in blue here. Little more bone, and the osteoclasts are going to open this center space. And so now you have just a little bit more bone produced, but you still have this whole metaphysis above. You still have that. You just have a little bit less. So the growth plates are just getting thinner and thinner and thinner. And every time the bones grow in length, it's just a little bit less epiphyseal plate that's left over until you reach puberty, and these epiphyseal plates turn into epiphyseal lines. And then it just blends in, and there's nothing left. And all of this is all bone. There is no more growth plates once you have reached puberty. So this story happens at the epiphyseal plates at the ends of long bones, both ends of long bones, all throughout childhood up to the end of puberty. So this is another picture of actually what's happening. So this is a very thick layer of reserved cartilage. This is your typical look of hyaline cartilage, although it's not very the staining is kind of a bit opposite to what we're used to. Zone of proliferation, you can kind of see here, they're lining up a bit here. They're definitely into columns over here, and they're enlarged, right? You see these lacunae are enlarging. They're just so much bigger than the lacunae here. They're enlarged, they're super enlarged over here, and calcification. So when you stain the tissue, the calcification actually pops up, like, ooh, this is where the calcium minerals deposited and not above, and you can see it because the extracellular matrix is staining a bit differently. So this is zone of calcification right here. This is very clear where zone of calcification is. And then zone of bone formation is below it, with the marrow kind of rushing in, which is what I drew earlier. So it's rushing in and breaking into these lacunae walls. It's going to break here. It already broke here and here. You see how it broke in here. And it's basically spray painting these lacunae with these osteoblasts, and they're going to produce the lamellae. All right, so this is just a summary again of everything that happened. So you can read that at your leisure. And this is an awesome X-ray that shows the hand of an adolescent, where you can see the epiphyseal plates. This is, this would not be the hand of a newborn, because all the long bones are done. They're all bony. You can see all the phalanges here are bony throughout their whole length. The epiphysis, diaphysis, epiphysis, all bone, except that, see the epiphysis here? There's this black line. A black line. What? We don't have 1, 2, 3, 4, 5, 6 bones in our ring finger. We only have 3. Proximal, middle, and distal phalanx, remember? But each one still has an epiphyseal plate in it that you can catch in an X-ray, and it's this black line. And it looks like phalanges only need 1 epiphyseal plate at one end. And you can even see them here in the metacarpals, right here. So cool. Okay. So let's talk a little bit about hormones, because we need growth hormone to actually promote this growth at the epiphyseal plate. So growth hormone comes from the pituitary gland, which we will see again in the endocrine chapter, and it promotes growth. And during puberty, testosterone and estrogen also are, quite involved with bone growth, because growth hormone is important throughout, childhood, and, a 5-year-old and 7-year-old and an 8-year-old, you still need the growth of their skeleton. When puberty starts, and you have now the androgens, testosterone and estrogen, those are reproductive hormones, you have an initial promotion of growth. So there's a growth spurt. So there is a renewed stimulation of growth. So you have like these quite a bit of growth at 13, 14, maybe even 12 for some boys, right? So 13, let's say 13, 14, poof, they start like growing really fast. And these hormones, they're causing other things as well, masculinization and feminization of specific parts of the skeleton. This is when the pelvis of a 5-year-old girl and a 5-year-old boy, when they were the same at 5 years old, they're actually going to start reshaping at puberty and becoming more of what they're supposed to be for male and female pelvises. when you have more and more of these reproductive hormones, the epiphyseal plates actually end up closing, and that signals the end of longitudinal growth. So puberty is basically the last hurrah of growth. So you have your last this final spurts growth spurts, and too much of these hormones will actually prematurely close these epiphyseal plates. Testosterone, for example, young men that have not finished puberty taking testosterone for, maybe those are anecdotal stories, but they're in the gym and taking testosterone for muscle growth, muscle mass, more muscle mass. They actually can stunt their growth, their skeletal growth, because of the levels of testosterone being too high. So the epiphysis and diaphysis end up basically being continuous, with the epiphyseal plate disappearing around age 18 for girls and 21 years for boys. So there's still growth in boys up to 21. That's why, levels of hormones is really important, and too much is not good. So the clavicle happens to be one of the last bones that stops growing at age 25. So that's a little bit late. So you'll see in your pathology course some of these disorders that are related to the skeleton, and you'll also see them in the context of the endocrine system. So these are kind of some of the clinical correlation here with too much growth hormone will lead to gigantism. If too much growth hormone during childhood, when the bones are still capable of growing in length, and you have this additional growth that happens during childhood. Acromegaly is too much growth hormone during adulthood, when there is no more epiphyseal plates to actually grow bones in length because they disappeared by then. But all of a sudden we have growth hormone that's increased in production all of a sudden in adulthood. Then what are we going to grow? We're going to grow the thickness of the bones. So that's what happens when growth hormone is increased in production during adulthood. Bone grows in thickness, and that's called acromegaly. You can see that in the different pictures of this patient woman. The features of her face and hands are what was most affected. You have thickening of the bones. And when you don't have enough growth hormone, you can, end up having a form of dwarfism. This can be treated by administering growth hormone during childhood. One of my students came up to me at the end of the lecture and actually shared his own personal experience with injections of growth hormone, because he wasn't kind of on the chart for growth. During his visits with the pediatrician, they caught this, and they addressed this by injections of growth hormone, which helped him catch up in length with his peers at his age. So I don't remember what age he was, if it was 7, 8, I don't know. But he's a normal looking college student that you would never think that he had that issue when he was a child. He's not very tall, but he's completely, normal looking. He's not dwarf. There are other forms of dwarfism that we can talk about in the endocrine chapter, that is more related to a genetic condition, where the torso is a torso and head are normal size, but the limbs are shorter than normal. So it has the dwarfs of these are in these conditions are not as symmetric, and that's called achondroplastic dwarfism. So growing in length and in width are the ways of bone growth. And we talked about bone growth during puberty and, during childhood and puberty. That's bone growth in length by endochondral ossification, right? This is what I just covered. But they really grow and remodel themselves throughout life. So the interstitial growth is in length. So this is, oh, actually I had written it here. Sorry about that. Interstitial growth, that's called interstitial growth, growing in length at the epiphyseal plate during, childhood and puberty, and then the plates close up. So what are we left with? We're left with appositional growth. This is growth in thickness, and this happens throughout life. So this is thickness, and it happens throughout life. How does that happen is because in the periosteum around the bone, there is an osteogenic layer of cells that are on the inside of that periosteum against the bone itself. So if the bone needs more bone tissue, these osteogenic cells are ready in a pinch to just kind of kick in and create bone tissue in the thickness of the bone. So the bone will start growing in thickness as opposed to in length. And of course, you have osteoclast activity always, just to kind of like make sure that the process is exactly what it's supposed to be. Okay, so let's talk a little bit more about minerals and how they are deposited. So mineral deposition. So when osteoblasts produce collagen fibers, these fibers, they spiral along the length of the osteon in alternating directions. I'm going to draw this over here. Osteons, they look like a wedding cake if you pull them apart from each other. The lamellae, I'm talking about the lamellae. Right, so these lamellae, I'm going to draw collagen fibers in green, and I'm going to show you these collagen fibers. When each lamella is put in place, these lamella are made of bone tissue, and which starts as a soft bone tissue, the osteoid tissue, and these are the osteoblasts producing collagen fibers and all the content that goes into the matrix and makes the bone tissue. These collagen fibers are put in place in an alternating direction. So one lamella will have them all laid out. It's not random. It's literally laid out very, very neatly in one direction, and another lamella, it will be the opposite direction. So it alternates from one direction to another direction. And this actually gives a lot of strength to the osteons. So this is really deliberate. So once these are fibers are put in place in these very specific orientation, they become encrusted with the minerals, which harden the matrix. So I'm going to draw the fibers of cartilage, right? So let's say they're here and going in this direction, like these over here, for example. They're going in the same kind of orientation. What we have is we have calcium ions that come in and deposit all over the surface of these collagen fibers. And they literally encrust them, meaning that they crystallize and they form a salt that you almost can scrape off. That's what I mean by encrusting. It deposits and hardens and becomes a crystal and creates this hardness. And now the soft bone becomes a hard bone. So that's mineral deposition. But the process of mineral resorption is basically now, how do we release these minerals back into the blood? We need to take them out of the bone tissue and put them back into the blood. And that's done by the osteoclasts. And I kind of already alluded to that, so I'm not going to like, draw too much here and talk too much. These osteoblasts are like little Pac-Man. They have hydrogen pumps in the cell membrane that secrete hydrogen, which will combine with chloride ions and produce this very acidic hydrochloric acid, right? There's a chloride ions, and they're going to combine to form hydrochloric acid. pH is very low, and this acidity literally dissolves those crystals. Basically, think of them as they just disintegrate, they melt off. I don't like to use the word melt, but they just kind of like disintegrate and diffuse out and away of the bone tissue and into the blood. And then, as I mentioned earlier, we also have enzymes that are being dumped into this resorption bay that digest the collagen. They literally are going to catalyze the chemical reactions to break down these collagen fibers into monomers and just kind of release all of these atoms into the blood. That's exactly how braces work, which I find is fascinating. Dental braces, they reposition teeth by creating this pressure on the bone on one side versus another. So there's more pressure on one side and less pressure on the other side. And whenever there's pressure, there is bone formation. I think I used I don't know if I used the example of the tennis player. I should have when I talked about deposition. A tennis player that is, right-handed, if you x-ray and look at their bones or an MRI, if you look at their radius and ulna bones, they're going to be thicker in the serving arm. That's how bone reacts to, stress and or bricklayers. They have very, very thick anti-brachium bones. So anytime you use your bones, they become thicker and stronger. So it's very good. So weight-bearing exercises is very good for the skeleton because it strengthens your skeleton. So increased pressure stimulates osteoclasts, decreased pressure stimulates osteoblasts, and that's how you remodel the jawbone. So I don't know if I said that exactly 2 minutes ago when I talked about the pressure. The pressure actually stimulates resorption, not deposition, resorption, and the lack of pressure kind of stimulates bone deposition. Okay. So why is calcium important? Why are we talking about, releasing minerals or depositing minerals in the bone, out of the bone, in the bone? Why? Because calcium is involved in muscle contraction. Calcium is involved in the action potential. So between neurons, neural signals. So for brain health, muscle health, calcium is involved in so many cellular reaction that promotes exocytosis. For example, the cortical reaction in the reproductive system when the oocytes receives the signal that a sperm cell is on the outside, and you have this reaction that takes place is thanks to the calcium rising in the oocyte. So calcium has just so many roles in physiology that is extremely important to regulate. So I'm going to draw here a blood vessel in red. Here we go. And blood levels are usually between 9 and 11 milligram per ml of blood. Okay. This is the range. This is a very narrow range, 9, 10, 11, not more, not less. 9, 10, 11 milligrams of calcium in the blood. If we drop from these levels, we need to replenish these levels and bring them back up. If those levels are too high in the blood, we need to get rid of some of these calcium ions out of the blood and into something else. So those levels have to be regulated so we can stay in that homeostatic balance of 9 to 11 milligrams per ml. So who's responsible for doing that? It is, let's see, what kind of color am I going to use? Let's just use green. It is thyroid. Oops, why so big? Thyroid and parathyroid glands that are going to be responsible. So this is the thyroid. And parathyroid glands are over here. They're on the surface of the thyroid, the posterior surface of the thyroid. You have a pair of parathyroid glands on both sides. Okay. So the parathyroid glands produce parathyroid hormone, and the thyroid gland produce thyroid hormone. A thyroid hormone that is more specifically not T3 and T4, your regular thyroid hormone, but calcitonin. So we'll talk more about the cells of the thyroid, which cells produce which hormones, T3, T4, calcitonin. Here, I'm just going to keep it as thyroid releases calcitonin, parathyroid releases parathyroid hormone. Okay, so which one's going to do what? Both of them are involved in calcium homeostasis. Calcitonin is going to be responsible when levels of calcium become too high. If levels of calcium increase, calcitonin is going to help tone it down. Okay, calcitonin tones it down. That's the way I tell my students to remember. If you remember one, you're going to remember the other, because the other is when levels are too low, when levels of calcium drop, you have PTH that kicks in to bring the levels if I write too fast, it's not going to write. Bring levels back up. Okay, so calcitonin is going to go, I'm going to say will tone it down. Right? So if levels rise, calcitonin tones it down. If levels drop, parathyroid hormone brings these levels back up. Okay, so I like to actually draw the vessel over here and calcium. Okay, so you have calcium, 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 and if these levels are too high, calcitonin will take the calcium out of the blood That's very important. We need to tone it down. We cannot go beyond higher than 11 milligrams per ml. We have to bring these levels back down. So let's get rid of this calcium. Calcium comes out of the blood. Well, what do we do with it? What are we going to do with calcium? What are we going to do with calcium? How about we just kind of shove it in bone? And that's exactly what's going to happen. This is a great way to kind of hide calcium because we don't want it to be circulating anymore. So we're going to have bone production. So calcitonin stimulates osteoblasts to form bone, because osteoblasts are going to make osteotissue, and once the osteotissue is made, we need calcium to come in and kind of like harden it. So if we kind of promote osteoblast activity, we're going to have usage of the calcium, and that way we can get rid of it from out of the blood. Also, calcitonin will decrease osteoclast activity. So osteoclast activity is going to come down while osteoblast activity will go up. We don't need to resorb bone. We don't want to resorb bone because we don't want more calcium to be released into the blood. So we tell the osteoclast to kind of like quiet down, go take a nap, just go away, go somewhere else. Don't worry what's going on here. And we tell the osteoblast, please, please, please make bone. We need to get rid of this calcium and you could use it up. Perfect. One more way, this over here was bone production. That's what we're promoting. We're promoting bone production. So calcitonin promotes bone production. Okay, and one more way of how we can do this is we can stimulate renal excretion. Let's put it in the urine and get rid of it that way. We get rid of it from taking it out of the blood and putting it into the urine. So this is at the level of the nephrons and the kidney tubules. Calcium is in that glomerulus, and it's going to be pushed out of the glomerulus into the tubules and into this urine filtrate to be excreted and out. And that's a great way of getting rid of calcium. Now, when calcium is too low, we have PTH that is going to PTH in dark green. So PTH is going to take it out of the bone and this is PTH. That's what it stimulates. Because if we take calcium out of the bone, it's going to end up in the blood. Perfect. We're bringing these levels back up, right? This is what these hormones did. They toned the levels down or they brought the levels back up. So here, how do we bring the levels back up? Who can we stimulate to have calcium all of a sudden free to go and end up in the blood? Osteoclast activity. So PTH promotes osteoclast activity. They're going to resorb bone, and that's going to release calcium. Calcium will go into the blood, levels will go back up. Shoo, we took care of the problem. So not only do we do that at the level of the osteoclast, we stimulate osteoclast activity, but with the help of vitamin D, so I'm going to add vitamin D in the story here. With vitamin D, we are also promoting absorption via digestion. So promotes, I don't want to write food here. I'm going to write absorption. Oh goodness, sorry about that. Okay, and this is with vitamin D. And that's why vitamin D is so important. It's also a hormone that is a synergist of PTH PTH and vitamin D work great together, and they're going to help with absorption of calcium from the diet through the intestinal wall. And when it comes through the intestinal wall, where does it end up? It ends up in the blood. So that's from food. Okay, so it's all very logical, but if you kind of draw it out and talk the story out, it can help you memorize what's going on, because it's a story and you're like, yeah, I can see this happening. I can see why we need to have the blast kind of crank up their activity so we can make bone and bring this calcium to harden the bone. Hey, we're taking it out of the blood. Well, if we need the levels to go down, that's perfect. So all of this is kind of logical, and hopefully this explanation helps you. All right. So basically, bone tissue is this reservoir of calcium. If you need calcium, it's going to be taken out of the bone. By the way, this reminds me to tell you, when you are pregnant and your baby's growing, and at 12 weeks, all of these long bones are little sticks. So it's endochondral ossification is taking place, starting at week 4 and beyond, with primary center of ossification, blah blah blah. If you don't have a good diet while you're pregnant and it provides extra calcium that your baby needs to produce these bones, the baby, the fetus, is going to take it from your skeleton. It's going to have the appropriate calcium, but you are going to be depleted from the calcium. Your skeleton will be depleted from the calcium. So one pregnancy after another and after another, if the diet was never that great, it could actually promote osteoporosis, and that's not very good for mothers. So you need to watch your diet during pregnancy. Okay, so very tightly regulated these calcium blood levels. Too much blood calcium leads to hypercalcemia. The heart can stop with too much calcium in the cardiac cells. Too little blood calcium, it's called hypocalcemia. You can have breathing issues with too little calcium. Calcium is very important for muscle contraction. So here are some of the diagrams, typical diagrams from textbooks about parathyroid and calcitonin, and you can kind of like study them, maybe after you draw what I just drew about homeostasis. Okay, so this is really what I said verbally. I'll just one slide for each hormone. So all of these functions are very logic if you are seeing what's the end goal, right? If we decrease calcium excretion, that means we're basically keeping it into the blood, if that's the goal of parathyroid hormone, which it is. Okay, and this is a slide about vitamin D. So, you can read about vitamin D. So calcitrol is the other name for vitamin D. Its synthesis starts in the skin. This is something we talked about when we talked about the integumentary system. I don't really require the memorization of the intermediary molecule names. Vitamin D3 is really important to the formation of vitamin D. This is kind of what you see in supplements. It's basically the precursor that will be transformed into calcidiol in the liver and transported to the kidneys. And finally, in the kidneys, we have the final form of vitamin D, which is called calcitriol. And this vitamin D is really important in bone resorption, excretion of calcium, reduced excretion of calcium, or stimulation of the absorption of calcium. All this to increase calcium levels in the blood, because that's what vitamin D does with PTH synergistically. There are more hormones that affect bone homeostasis, of course, vitamins, growth factors, So it's really more complicated than this, but this is a good basis for understanding, bone homeostasis is understanding calcium homeostasis. So other minerals that are needed for remodeling, besides calcium, phosphate ions, magnesium, manganese, these are all just important in general for bone formation. Vitamins that are important, vitamin D, vitamin C, vitamin A, and B12 are important for bone remodeling. And if you don't pay attention to your skeleton during life, the chances of osteoporosis are greater. So it's a very, very common bone disease in older people. Their bones are just not as strong anymore. The lamellae are fewer. There's more spaces in the spongy bone. Bone resorption outpaces bone deposition. That's why weight bearing is so good for bone deposition, right? That weight, it increases bone thickness, and it just helps avoid osteoporosis. So it happens in menopausal, postmenopausal women, older women. Bone is very brittle. These are just some pictures that show that. And literally, like if they fall on their side, they can break their hip just like that. Bones break very easily with osteoporosis. So the spine can stack up, and that's how you end up with kyphosis. Remember, this is one of the conditions we just kind of mentioned in the skeletal system chapter. And that's it. Those were my final clinical correlations that I have for bone. Okay. Thank you for your attention. And that's it.